Raji.
Yep.
No.
Okay. Well, welcome everyone. I'm aware that it's, for some of you, it might be your first function with the NZSE, so a particular welcome. Just to let you know that our AGM will be held immediately following the presentation. So if you'd like to stay, please do. If you're interested in joining the committee, we would love you to stay and introduce yourselves. For those of you who don't know much about the NZSE, we're a society that has been set up for the sole purpose of promoting and advancing both the study and practice of endodontics. Our members are specialists and general dentists, and we are all about best practice endodontics. If you're not already a member, we would encourage you to become a member, as well as CPD evenings like this, which will be held every quarter. Your membership gives you reduced registrations to any courses or workshops that the NZSE is involved in. You'll receive 2 NZSE journals a year, and you'll have complimentary access to the Dental Trauma Guide, which is an outstanding resource to have on your work desktop. So if you remember and you haven't yet received your link to that trauma guide, please do make contact. info@nzse.co.nz would be the best email. And if you're interested in becoming a member, make contact as well. So info@nzse.co.nz. So Kesh, over to you.
All right, cool. So a warm welcome to everyone. Thank you for participating in this Zoom meeting. I've got the pleasure to introduce our guest speaker, Dr. Patrick Caldwell. He is a registered specialist in endodontics. He graduated in dentistry with honors from the University of Queensland in 1998 and went on to work for the Royal Australian Navy, both ashore and at sea. During this time, he undertook advanced training in restorative dentistry, and in 2002 was elected a fellow for the Royal Australasian College of Dental Surgeons. In 2003, Patrick began a 3-year full-time training program in endodontic therapy and microsurgery, graduating with a Master's of Dental Science in Endodontics. He has since gone on to complete additional advanced training, graduating with a Master's of Clinical Dentistry in Implant Dentistry. In 2006, he returned to work with the Royal Australian Navy, and was also engaged as a visiting specialist at the Sydney Dental Hospital. In 2009, Patrick moved to Shanghai, China, where he was the only endodontist in a city of 21 million people. Excellent. Upon his return from Shanghai, Patrick has now opened Brisbane Microsurgical Endodontics in South Brisbane, where he continues to practice, he continued to practice for 7 years. Oh, sorry about that. Upon his return from Shanghai, Patrick opened Brisbane Microsurgical Endodontics in South Brisbane, where he continued to practice for 7 years until 2018, where currently he practices at Sunshine Coast, Queensland, Australia. Further ado, I'd like to invite Patrick to take the stage or the Zoom session and present to us. Over to you, Patrick.
All right, thank you. And thanks for the invitation. I guess, what we're talking about today is outcomes, and outcomes is what we're all about. And there's a little period there where I purchased some software called TDO software, and I started getting exposed to a few different concepts in terms of outcomes. And Dikesh will probably be familiar with some of this, and it's probably shifted the way I think about outcomes a little bit. So I want to go through a little bit of that, and then we'll do a bit of theory, and then we're going to get very practical at the end, and we'll go through some cases. So this is an article that was in the European Heart Journal, and they talk about the goals of medicine, and they say there's really only 3 goals of medicine, and that's to improve the quality of patient's life, improve the length of the patient's life, and to do so at a reasonable cost. And they say that any other endpoint that's measured is a surrogate, so it's not an actual outcome. And they give some examples. For example, if you have a higher HDL cholesterol, you're at a lower risk of cardiovascular events like stroke and heart attack and that sort of thing. And so there's some drugs around that will lower your HDL. And in some trials, they can show that the drug will lower your HDL, but you don't actually have a lower risk of a heart attack or a stroke. And in some cases, you can show that a drug will lower your HDL, but you actually have an increased risk of a heart attack or stroke. So on one hand, we've got the outcome, which is the heart attack or stroke and the effect on your quality of life or your longevity. And on the other hand, we have the surrogate, which is the HDL. So surrogates are not events, they're measurements that we take. And we usually use these for things like research because you can measure them fairly easily and you can measure them over a much shorter period of time than the outcome, obviously. So very good for research. All right, so this is John Ioannidis, and he is the Professor of Health Research and Policy at Stanford University and co-director of the Meta Research Innovation Center. And he's become a little bit famous throughout this COVID era because of some research that he produced. But he was at one of our endodontic meetings, I don't know, maybe 5 or 6 or 7 years ago, and he was talking about outcomes in endodontics. So I'm just going to play this video and hopefully it comes through for you.
What we want to see though down the road is the outcome, and now I need your help. Which outcome one would need to choose? I would like to choose an outcome that would really be clinically important. That would be tooth loss or something serious happening. So that would be something that does matter. Even though the original observation is just a radiographic sign, the outcome should be something that matters. I wouldn't be happy if you tell me that the outcome will be just a change in the radiolucency a few months down the road. Why? Did I say something stupid? Or okay, I didn't even know what I said. I said that I would not be interested just in the radiolucency. I would be interested in something that clinically would matter as the outcome. But I have no problem to randomize people based on something that is, an asymptomatic sign.
Okay, so he's talking about outcomes in endodontics being things that, what he says, clinically matter, like tooth loss. And he says outcomes are not things like the radiographic signs or the radiographic findings.
Now, if you read the methodological literature, to get strong evidence of surrogacy, you need 2 prerequisites. One, you need to have randomized evidence. So you cannot have a strong surrogate unless you have already run a randomized trial that has shown that what radiolucency evolution told us is exactly also what we saw in the clinical outcome. Number 2, you need a large treatment effect. So you need a randomized trial that shows a large clinical benefit, and then you can take whatever candidate surrogate marker, map it along with that benefit and see that it does map and comport very nicely with the clinical benefit. In this case, there's no randomized trial, let alone treatment effect. So, it would be completely a belief that, radiolucency is such a great marker.
All right, so basically he's talking about how surrogates would be validated. So in our world, you would want a study that shows that if you heal radiolucencies, patients always have a good outcome in terms of their patient-centered outcomes. And if you don't, then they always have a bad outcome. So this is a periapical index developed by Ostervik in 1986, and it was based on a distribution of root-filled teeth from a thesis that was done, I think, in the 50s or something by Brinoff. And he sort of assigned the appearance of the radiograph to a number, and then that number was used to decide whether the treatment had been a success or failure. And this or a variation of this has been used in endodontic research and outcome studies for quite a long time. Which is interesting because, you know, the first take-home message is that radiographic findings are not outcomes. So outcomes, if we think about what our patient-centered outcomes are. Sorry, I heard someone talking there. If we think about what our patient-centered outcomes are, if we're talking about longevity and quality of life and cost, then in dentistry, we're probably thinking of things like how long the tooth lasts. Quality of life will be things like function, pain, aesthetics, and cost, obviously, what it costs the patients. So this term patient-centered outcomes is certainly becoming a little more popular. This is the Patient-Centered Outcome Research Institute in the US. And their charter is basically to promote research that uses outcomes that matter to patients as the measure, and provides information that can be understood by physicians and explained to patients in a way that the patients can understand so that they can make informed decisions on their treatment. And this is the second largest funder of research in the USA. So it's certainly gaining a bit of traction. In the implant world, this was a systematic review, and they looked at all the studies they could find on peri-implantitis. And they said that the endpoints that were looked at were attachment level, bleeding on probing, pocket depth. And they said that there was no true endpoint, no patient-centered outcome that was described in any of those studies. And they said that, suggested there should be some sort of consensus on what endpoints should be used, what surrogates should be used to measure, and some effort made to validate those. So they're suggesting that there should be some studies that show that if you have increased probing depth, or if you have bleeding on probing, then you're more likely to suffer a functional deficit, or more likely to spend more money, or more likely to have an aesthetic problem. And these are things that we assume are true, but they haven't been validated. So in the endodontic world, in terms of our outcomes, there are a couple of larger studies, and this is probably one of the larger ones. In the study, there were, let's see, if we look at the exclusions, teeth with perio, teeth with questionable x-rays, teeth that had previous surgery were excluded. And of the 924 teeth that were included, if we look 2 years down the track, 702 teeth were actually available for analysis. So in 2 years, we lost, around about 20% of the teeth. And then a lot of analysis was done on the preoperative factors using a multiple logistic regression model. And then we came up with these effects. And here you can see highlighted the odds ratios. So normally in a lecture like this, I'll ask someone to explain what odds ratios are. And Dikesh, can you explain odds ratios? No. So it's something that most people can't explain, and I don't understand them that well either. But what we do know is that these numbers are they represent fairly large effects in a lot of cases. So for example, in the case of the widened periodontal ligament, that 0.86 means that there's a reasonable chance if you have a widened periodontal ligament, you're more likely to lose the tooth, to have treatment fail. And next to it is a confidence interval, and that confidence interval is quite wide. So the effect, the range of effects that are seen range from very likely to lose your tooth to very likely to have treatment be successful and retain your tooth. So it's really quite wide there. If we go down to this factor, additional use of chlorhexidine as an irrigant. So that's saying if you use all your normal irrigants and then you add chlorhexidine as an additional irrigant, there's a very, very strong effect that causes you to lose your tooth. So if you think about that, does that really make much sense to you? You use more antibacterial irrigants, you're more likely to have the tooth fail. It doesn't really make logical sense. So this is Roger Lewis. He's the co-leader of biostatistics, study design, and clinical data management, and a professor of emergency medicine at UCLA. He was also at an endodontic conference, and he was looking at the same research and talking about outcomes.
One of the challenges that you all seem to have is how to interpret data that are gathered in roughly this idea. We have a large practice, seems to be often done with graduate students, and we enroll everybody, we collect all kinds of data about their baseline characteristics, what treatment was given, which we didn't really control, what happened, like that perforation thing, and what was the flap or inflammation, what did you call it? Flare-up. The flare-up thing, okay? And then some outcome, and let's just assume it's tooth survival so we don't have to have another argument over radiographic findings, okay? And you have all these variables, and you want to ask the question, how important, and this is an observational study, and you want to, just for prognostication, you want to answer the question, how important is each of these variables? Meaning, if the patient smokes, should I tell them that that raises the risk of failure or death of the tooth by some amount? Okay. And there's two comments I want to make, or two general concepts. One is the difference between prediction and variable selection, and the other is collinearity. So hopefully I will remember those both. Okay. When you do a regression model basically asks the question, how much do these independent variables affect the likelihood of the dependent variable, which we're going to use as our example of the dichotomous outcome of tooth survival. And you have a long list of predictor or independent variables. Okay? The way these studies are generally done, they have a table at the end, and boy, you guys bury them 20 or 30 pages in. You guys have the most verbose literature I have ever read, okay? Where you have a table where you list the variables that survive through some complicated model building strategy. Usually something like, we screened each of the variables independently to see if it was associated with outcome. Those that were associated with outcome with some particular p-value, we put in a multivariable model. Then in the multivariable model, if they still look good, we kept them. If they didn't look good anymore, we dropped them out. And we did this through several stages until we had our 12 predictors of outcome, or 13 predictors of outcome. Does this sound familiar? I don't know if you guys, okay. So that was about 20 pages I just did right there, okay? Okay. And when you look at that table, there's two pieces of information a clinician might take from it. One is, what are the variables that are important? That's called variable selection or identification of the predictors. The other is, how important are they? So those would be the odds ratio measures for how much does having one of these predictors of a bad outcome increase the chance of tooth failure, tooth death, okay? Unfortunately, a regression model is fundamentally aimed at answering neither of those questions. A regression model is a way of doing prediction, which is saying if you had a new patient in whom you had measured these 13 variables, can you predict what their probability is of 5-year tooth survival or 4-year tooth survival, whatever it is? That's what a regression model does. So the techniques that are used in at least the papers I looked at, where you do this screening of multiple variables and let the data decide which ones survive, so that last table in the manuscript, is highly unreliable. And what I mean by unreliable, I mean this in a very rigid sense. What I mean is, if you did the exact same study again, you used the same inclusion exclusion, the same graduate students, just different set of patients, and you did the whole thing and you went through that whole model building strategy, the chance that you would get the same list of predictors is very, very close to zero. It's unreliable, meaning you can do the same thing more than once and have a different result, unlike the car that's reliable. Okay? So I place virtually no stock in the specific identification of the predictive variables.
Okay, so that was a long video, but it's pretty good to get some expert assessment of those sorts of studies that we have. Certainly when I was going through postgrad, you know, I would look at those things and place quite a lot of value on them because they're the biggest studies we have that look at outcomes in endodontics. And the other thing he said was that basically the take-home message, you can't use that data to help you decide what's going to work on a patient sitting in your chair by looking at these preoperative factors. So you can't use that sort of data to help you predict what's going to happen, and you can't use that sort of data to tell you how to treat someone as well.
So there's this whole set of observational data that you seem to be enamored of in your specialty that I have grave concerns about. And the alternative is to actually try things that, and the selection of what you try should be informed by the models that you have or the uncertainty you have in those models, and actually see what happens and do randomized controlled trials. And I think that if you don't change your mode of doing research to doing randomized trials with good long-term follow-up, that you could invite me back in 5 years, and like our esteemed host, I could just play a tape of my talk this time and it would still apply. I think you're going to have to do that to break out of this mold.
All right, so this is a randomized controlled trial. So there were 82,000 men who had a PSA test, and 2,664 received a diagnosis of localized prostate cancer. 1,643 agreed to undergo randomization. So this is a inclusion. There's an inclusion chart from that study, and you can see they were randomized either to monitoring or to surgery or to radiation therapy. And you see at the top there was 2,664 patients were eligible, and then at the end of the study, there were almost 2,664 patients. So there were 14 that were lost to follow-up. And those 14 patients, they weren't available for secondary outcome, but they were able to be assessed for the primary outcome, which was death in this particular case. So that was done over 10 years, and the primary outcome of death was able to be measured for everyone that was in that study. So compared to our endodontic study, where we lost 20% of our participants after 2 years, and it's a fairly different sort of study that we're looking at. Now, realistically, we're not going to be able to conduct those sorts of studies in endodontics. It's just not going to work. You're not going to get the patients, and you're not going to get them to hang around. So, you know, there's this whole concept at the moment where some practitioners like to be fairly minimal in the way they treat. They try to conserve dentine, they have smaller preps. If we wanted to work out whether this new minimal approach was better than the old traditional approach with a larger access and larger preps and straight line access, we would really need to conduct a randomized controlled trial, and we'd need to get a whole lot of different practitioners doing the work, so it wasn't just relying on one person. And those practitioners would have to be able to perform the minimal intervention, and they would have to be willing to also randomize their patients to having and willing to perform the more conventional type of treatment as well. And then we need to follow them for something like 10 years and measure the outcomes in terms of function and cost and quality of life, aesthetics, that sort of thing. And there would need to be a big enough difference for it to be measured with the number of people that were in the study. So you might need 2,000, you might need 5,000. The smaller the difference, the greater the number of people you would need to have. And so it's pretty difficult for us to conduct those sorts of studies. In the implant world, we see studies like this. So this is a 10-year survival retrospective, and it's pretty good recall rate. So only 6 of the implants were lost to follow up out of 511. 2 of those had disease. Sorry, six of the implants were lost, were extracted or removed, and 2 had disease. Now, something that's interesting here, when we look at these studies, if you look at the first 100 of those implants, they had an inclusion criteria where there had to be partially edentulous patient, had to be sufficient bone to place the implant without any sort of augmentation. And the work was all done by Danny Busso, who's one of the world's leading implant clinicians. All these patients were followed up through the university program. And essentially, this study is just an outcome study based on what can happen in the best possible scenarios. When you do your endodontic training, there will be a lot of situations where you see very compromised teeth and you say, okay, let's have a go and let's see what happens. We'll try and pull this broken file out. We'll repair that perforation. There's large infections associated with the teeth. There's periodontal disease, and we treat these teeth and see how they go. And I think you'll find the most implant postgraduate studies or programs, you're probably not getting patients in who are smoking with periodontal disease and saying, let's just put some implants in and see what happens with them, see how it goes. It doesn't really happen. But the implant world is definitely a little bit further ahead, I think, than the endo world in terms of this. So this is at a European workshop on periodontology in 2011, and they were actually looking at outcome studies, and they reported that many of them didn't report the dropouts and the biological and technical complications weren't reported well. And they suggested even back then that all clinical studies should report on patient-reported outcome measures and aesthetic indices. The ITI conference that was supposed to be held in Singapore this year was solely, its main focus was patient-centered outcomes in implant dentistry. This was an outcome study in implant dentistry. I just wanted to have a look at. There was 900 implants placed in 87 practices. So there was a range of dentists doing the work, general dentists and specialists as well. And again, there was this univariate analysis of risk factors. Something that is sort of interesting, you see in these cases, if we go back to where our research was being assessed, and the point was made that if you repeated those studies, you wouldn't expect to see the same results coming up. But certainly in some of these, where there's a situation where we do see the same results coming up, even though the design might not be perfect, then if we see the same factors coming up all the time, then that certainly adds weight to that. And we do see the same factors at least in these implant outcome studies in some cases. So things like a history of periodontal disease, you see that a lot, poor quality bone, and even the clinician that does the work. But something that I think is really interesting in this study is that some patient-centered outcomes were assessed. And they were assessed in terms of what the patient thought and what the practitioner felt. So if we look at the appearance of the soft tissue, so this is the aesthetic value of the soft tissue around the implant. The dentist judged it as being excellent or no deficiencies 84% of the time. And the patients judged it as being, or were extremely satisfied 58% of the time. So interesting that there's a bit of a differential there. If we look at the restoration, again, 83% of the restorations were judged as being very good by the dentists. And that dropped to 66% when the patients were judging them. So just pretty interesting in terms of the surrogates that we're using to measure our outcomes and what the actual outcomes are according to our patients. All right, so this is Sander Greenland. He is a professor of epidemiology and statistics at the University of California. So he's an epidemiologist, all about statistics, you know, theories and methods and that sort of thing.
Even if every study was a perfect randomized trial, I would bet you that we would still find ourselves with lots of big problems because of the difficulty that humans have in interpreting data, even from perfect studies. Right?
So it probably doesn't matter how good the studies are. We are going to interpret them however we feel we want to interpret them. So when I was going through my endodontic program, there was a bit of talk, you know, people would say to me, don't you think endodontics is dead? Because implants are coming through and they have much better outcomes. And that certainly seemed to be the way that it went for a while. There were a lot of dentists that would not perform endodontics and would prefer to extract teeth and have implants placed. And there's certainly been a bit of a swing back now. So if we look at these papers that were published, so this is 2016. So Nicholas Lang there, one of the bigger names in implant research, is saying that studies have demonstrated that those with less training in implant dentistry and periodontology will generally apply reduced efforts to save teeth, and that the erroneous belief of implants yielding a better long-term prognosis has now clearly been rejected in several comparison studies and systematic reviews. Teeth even compromised because of periodontal disease or endodontic problems may have a longevity that surpasses by far that of the average implant. And here as well, it's becoming apparent that implants suffer more biological and technical complications than teeth and require more ongoing care. This is from Dennis Tarnow, one of the, also a very big name in implant dentistry. We can expect that in 10 years' time, 100,000 of the implants placed this year will have peri-implantitis with 30% bone loss. So that was 4 years ago as well. And he sort of made the point that orthopedic surgeons will tell their hip replacement patients that they can expect to have the procedure done again in 15 years. And that at least in implant dentistry, we shouldn't be telling our patients that these implants are going to last the rest of their life. When we look at endodontic studies, or we look at the failure of endodontically treated teeth, we see quite repeatedly that the majority of these teeth fail prosthetically. So what that means is the crown breaks, so the tooth breaks or the restoration breaks, and they can't be restored. Or we see occasionally root fractures, and occasionally we see endodontic failure. So this is Professor Terry Walden. He's a prosthodontist who is pretty good at keeping stats on his patients, and he looked at 7 years of data. There was a period where he started restoring a lot more implants in his practice, and he looked at 7 years of data before he started restoring the implants, and then 7 years of data after that. And using a bit of statistics to sort of stretch that over 10 years, what he found was in the pre-implant era, a root-filled tooth was more likely to fail and be extracted than a vital tooth. But in the post-implant era, there wasn't any real difference at all. Again, looking at the failures, there were some tooth fractures, there were deep fractures, either through the root or subgingival, bit of gum disease in the bridges, and very few endodontic failures. So this is what he had to say. And going on to say this. So he felt that with the introduction of the implants, he was less likely to try to retain a broken down tooth. And instead of having bridges, he would have an implant and then have individual crowns on teeth. And instead of long span bridges, they've been broken up with implants and have shorter span bridges if necessary. We are starting to get a few more studies looking at patient-centered outcomes in endodontics now. An example is this one. So patients who were treated either with implants or endodontics, this is just a survey basically, but it was pretty interesting. The endodontic groups really didn't like the length of time in the chair, and they were often surprised at how little pain was involved, which probably wouldn't surprise most of us. The implant groups, funnily enough, mentioned that they tend to chew away from the implant because they want to protect it. They find that they needed to clean around the implants more, so they needed to brush more and floss more, which probably also wouldn't surprise those of us that restore implants or place implants. And interestingly, there were some complaints in the implant group about the aesthetics of the outcomes, the aesthetic outcomes, because again, to do occasionally with some metal showing, but also to do with the loss of the papilla, especially in those aesthetic areas. And if you look at endodontic outcome studies, in fact, I've never ever seen aesthetics assessed in any of our outcome studies, where it's a key assessment criteria in the implant studies. And probably if we started to look at them, we'd probably find that typically the endodontic outcomes aesthetically would be, I suspect would be better anyway, apart from the teeth that have been discoloured. Now, are there any questions coming through at all, Dikesh?
No one's asking any questions, so
excellent.
We're good to carry on.
All right. So carrying on from this, I looked at 5 consecutive days of treatment, and this is, I don't know, maybe a year ago, and I looked at all the patients I was seeing who had root-filled teeth, and I went back through their histories as far as I could go. And so we're going to look at these cases, and we're going to judge the failures that occurred, and we're going to judge them as endodontic failures or as tooth structural failures. And the endodontic failures will be teeth that we could have retained by retreating the endodontics. So a pure endodontic failure. So we could retreat the endo and the tooth would be functional. Tooth structure failures will be anything where endodontic treatment alone wouldn't have been able to save the tooth. So this is all very warts and all and real world. And so we're going to go through and have a look at a few cases. So this is the first case. This is Amy. This tooth was treated 3 years prior by a general dentist, and she'd had symptoms recently. So you can see there's a radiographic finding there. And cone beam really didn't show any deficiencies in the treatment. You can see it's a fairly thorough root canal treatment. It looks like all the canals were found, but there is this apical finding. So, you know, potentially there could be a little crack in the apical part of the root. She was very, very keen to retain that tooth, and I didn't know how well it was going to go, but we went in and dressed it. We found a little bit of anatomy, and there was at least resolution of symptoms and some healing. So she's going to go on and at this stage, at this short stage anyway, have the crown replaced and hold on to the tooth. So that would be an example of an endodontic failure, because we've treated it and it is still functional. All right. So next case, we're going to have a poll, I believe, Dikesh. So this is the first poll. All right, so this is Malcolm, and this is an OPG from 2007. So look at this 2007 X-ray. He is going to lose, what did I say? one tooth over the next 13 years. So everyone just have a look at that, that x-ray and tell us in the poll which tooth we think is going to be lost. So I'll give you a moment to go through that. All right, so 13 years time, which teeth are going to be lost? Well, let's have a look. In 13 years, these teeth are all present, and this tooth developed some caries and it was extracted. So that's an example of our tooth structure failure. The endodontics didn't fail you, but the tooth was extracted because it was not restorable. All right. Okay, so this is our third case, and this is Greg. He had root canal treatment at least 30 years prior. He told us it had been avulsed, and when we looked at the cone beam, there's a buccal swelling, we had deep probing, we had pus, and we didn't really think that this tooth was likely to respond to any treatment, and so it was extracted. And when we extracted it, we could see that there's been a bit of cementum delaminating in there, and that was pulled out of the pocket. So it was replaced with an implant. So we will call that we're going to call that a tooth structure failure. Because even though there was some endodontic infection, there wasn't an apical finding, but I don't think we could have retreated that and had an outcome. All right, so next case, this was Brooke. She had root canal treatment performed 17 years ago. The tooth actually wasn't in occlusion. However, she had repeatedly lost the post and crown. So that tooth was judged as being non-restorable and it was extracted. So she'll be getting a resin bonded bridge, or she's got a resin bonded bridge now to replace that tooth. So again, tooth structure failure, endodontics was fine. All right, next case, Michael. This is an x-ray from 2011, so 9 years ago. The root canal treatment is older than that. Tooth was restored at that stage, 2011, and 8 or 9 years later, he presented with a fracture. So you can see through there. It had the apical finding the whole time. So this was from 2011. We had an apical finding there. And in 2019, there was an apical finding, but the tooth had fractured. It had never been symptomatic over that period of time. So tooth was judged unrestorable and it was extracted and an implant placed. All right, so that's another one in for our tooth structure failure. All right, so this is Elsa, 28 years old. She had no symptoms at all. You see the root filling, not sure how old that was. So what do you imagine her complaint is if she has no symptoms? So here's a clinical view, and this was her complaint. So an aesthetic failure. So we were talking before about how many endodontic studies measure these aesthetic outcomes, these patient-centered outcomes, and there's very few as far as I know anyway. But despite this radiographic appearance and lack of any radiolucency and symptoms, I don't think we can really call this tooth a success. And it's a tough tooth to treat successfully because somehow we've got that dark area above the root annoyed her. So somehow we've got to treat this aesthetically. It's pretty difficult to bleach that internally while there's a fibre post in there, a large fibre post. From an implant point of view, this is a very, very difficult case. You know, thin biotype, there's recession, triangular teeth, very high lip line, and high aesthetic expectations. So So this is, this is a difficult case, and I'm not sure exactly what she's going to do. She got referred to Tony Rotundo to look at some options, and we didn't find out. I think at this stage she's still got the tooth there at the moment. So even though it hasn't failed, we're going to put it in a tooth structure failure rather than endo failure. All right, so let's go on to our second poll now.
Pat, just
yes.
There's a malfunction with the polling, so
okay.
I might have to just flag that.
I saw that there was 0% chosen.
It's either the I couldn't fill it out, so I didn't know what the feedback was, but
all right.
we might just you might just carry on with other polls. Sorry.
Yeah, that's all right. No worries. You can have a look at this anyway. So this is Colin 2010. So 10 years ago. So 2 teeth are going to fail over the next 10 years. So if you look through here, we've got a 1/6 with some silver points. So this probably wouldn't meet our endodontic standards these days. The 1/2 is root filled. It has a post of some sort in there, hopefully. We can see over on the second quadrant, we've got posts, root fillings. All of the root fillings seem inadequate and short. That molar has particularly poor root canal treatment, number of root filled teeth in the lower arch. So 10 years later, what do we find? Well, we find that the 1/2 has been extracted, and he was actually presenting for this lower incisor. There was swelling around this tooth. Cone beam showed there was no obvious missed anatomy, but we had this lateral lucency, and I just didn't like the idea of doing any further treatment to that tooth, and so it was extracted. So that's going to go into, well, let's see. We're going to put it in a tooth structure failure. This is what happens. So a bridge was placed. His dentist placed a bridge. They sent me these x-rays, and 6 months later, he presented with swelling again and a sinus tract. And we can see these lucid areas down through the extraction socket, and there's the cone beam. You can see that lucid area around there. And we open it up, and again, we found a whole lot of delaminated cementum in there. So we pulled all that infected cementum out of the extraction socket, and then it healed. So again, endodontic treatment wouldn't have been able to help that tooth. The problem was the tooth structure. All right, next patient, Rianne. So he had root canal treatment 5 years prior. He had no symptoms, had never had any symptoms. This was an incidental finding on a screening OPG. He came in and we talked about his options. You can see there's a separated instrument in there as well. We offered him retreatment. Maybe in a really good day, I might be able to retrieve that instrument, maybe not. And he elected to have that tooth extracted. So there was an apical finding, separated instrument, no real indication of a fracture. So asymptomatic, but that is clearly an endodontic failure. All right, we'll get through a few more here. This tooth, this was Anne, I think, and she had this tooth extracted just before she came to see me. So it had been root treated 10 years prior, and it had suffered repeated fractures. There were apical findings. It had never been symptomatic in that time. So over the 10 years, it had never been symptomatic. However, it had bits break off it, basically. And it was never restored with a full coverage restoration. So that was extracted and an implant placed. So again, even though there were apical findings, the tooth was extracted because there wasn't enough tooth to restore the tooth, or to restore it properly. All right, next patient. So these are all sequential patients that I saw. So we're excluding primary endodontic treatment. These are all patients that we saw to deal with root-filled teeth. So this one, John, he came in, this tooth was symptomatic. It had been root-filled, I think, 5 years previously. Cone beam, no real indication of any fractures, certainly some missed anatomy, probably some, well, definitely some inadequate endodontic treatment. He was treatment planned to have retreatment done and then cancelled his appointment and didn't come in. I'm not sure if that had to do with the tooth becoming asymptomatic, but clearly that's an endodontic failure. We'll put it in there. All right, next one, Andrew, trauma 20 years before. He had swelling. We retreated those teeth and treated the non-vital teeth, and there was initial healing at least, and the symptoms resolved. So we'll put that in an endodontic failure. Next patient, so these are just sequential, forget this guy's name. Root canal had been done just over 2 years prior, hadn't been restored. There was a buccal root fracture and we couldn't treat that. So it was replaced with an implant. So again, failure of the tooth structure. Joanne, root canal done 5 years previously by a specialist. She was horrified at the thought of losing that tooth. She had very deep probing and lots of bone loss, and that tooth had a root fracture. So it was extracted, leaving a nice big hole, and replaced. So again, a tooth structure failure. Sandy had the root canal done in 2014. Oh, so this is an X-ray from 2014. 2019, and we've got caries, and this tooth was extracted. So another tooth structure failure. All right, so this was to be our final poll. This is Merrin. So this is an OPG from 2012. So we've got 8 years later, and she lost 1, 2, 3, 4 teeth, I think, from memory. So we've got 1.6 has a separated instrument, probably substandard endodontic treatment. 1.5 has a fairly dense filling to the apex. 1.4 seems to be filled to the apex with a post. We've got really inadequate endodontic treatment in 2.6, 3.7, dense fillings to the apex, and 4.6, we've got inadequate endodontic treatment. All right, so let's see what was extracted. Well, this one was extracted, so it broke and was unrestorable. This tooth also broke and was unrestorable, so it was extracted. That tooth was root filled by Bayardo and crowned. This tooth's doing fine. So 8 years later, the inadequate endo tooth is doing fine. This tooth is doing fine. And both of these teeth broke. So the 5 first and then the 4 afterwards. And they were extracted and replaced. So we've got 4 more to add to the tooth structure failure. All right, we're almost there. So John, this was him in 2015. We can see that there is, or that tooth was root filled at that point. So that was a primary treatment. There's an apical finding on the 3.7. So this was at this point 5 years ago. Intra-radicular bone loss, probably a strip perforation. 3.6 was root filled in 2017, and 3.7 was still there at that point, although the restoration had broken. And then 2019, the tooth was extracted because the restoration broke again. So the tooth was asymptomatic during that 5-year period. And this one at the top is still doing fine. So another one that has failed due to tooth structure failure. So probably the take-home message, at least in my practice, that we see there is that the restorative factors usually trump the endodontic factors. And when we go back to those things that we looked at that we consider to be important when it comes to good endodontics, and we look at those factors that were highlighted from our endodontic outcomes studies, and it includes things like what concentration of sodium hypochlorite's used, what types of irrigants are used. The factors that tend to come through in the endodontic outcome studies more commonly are things like whether the tooth has been restored with full coverage restoration, whether the tooth is the last tooth in the arch, or whether it's lone standing, the number of teeth beside it. And those things tend to come down to occlusal load as well. So I don't think there's any argument that things like finding all the canals, getting to length, debriding well, cleaning well are very important when it comes to endodontic outcome. But in terms of the outcome of the tooth itself and the patient-centered outcomes, sorry, my dog's just come in, it tends to be how well the tooth can be restored and how well it can manage occlusal load. Sorry. All right, so this is Steve Goodman. He's the Professor of Medicine and Health Research and Policy at Stanford University. He's co-director and co-founder of the Meta Research Innovation Center at Stanford, which is a group dedicated to examining and improving the reproducibility and efficiency of biomedical research.
I do think that doctors or all clinicians in general have to be very humble about what they think they know in terms of outcomes, and that's been the biggest problem, is that every caregiver often thinks they know better how to treat the collection of people, but when subject to actual clinical trials, often that intuition is not borne out. So to know when to take the clinical trial result and when to contravene that result in a particular case is a very, very tricky area. Maybe it'll come up more as I talk. It almost doesn't, you almost can't talk about it in the abstract. You have to talk about particular cases, because it very much has to do with how well you understand the processes from beginning to end in a particular patient. Usually there's a gap. Usually you can predict very well, 2 days hence, but you really can't predict out here. And that's what the clinical trial does. It goes from here to here. It says, we give this therapy today, 1 year later, this is the outcome. But there's a lot of stuff in the middle that may leave out. Now, you think you have a lot of intuition about that stuff in the middle. Maybe you do and maybe you don't. And maybe it doesn't make a difference. A lot of things that we think we know, we might be right, but it doesn't make a difference. So...
are there any questions now?
No questions yet. You've done a very good job, Pat. So no one has any questions.
All right.
All right. So that's the end.
All right. Well, thanks for the invitation, and best of luck with your AGM. I hope you get a few people staying on for that.
Yep. Just a couple of things. I'd like to just ask Mike Jameson to just give you just a thank you. So I'll ask him to unmute. 1 second.
Sure. Can you hear me?
Yes, certainly.
Look,
Yes.
Pat, thank you for an excellent presentation. which really highlighted the importance of all of us keeping an open mind with respect to research and questioning the paradigms that we've lived with, and learning to keep an open mind and being prepared to rethink things. I think the clinical perspective you brought was extremely helpful. It just brought things back into line and really showed that the importance of reflecting on those aspects and being careful about some of the criteria in some of the research. And we're strongly encouraged to have research-based practice, but it's useful to have guidance from people with your experience to point out the research and give people new ideas and help us to think in new ways. So it was an excellent presentation.